Well, good morning and welcome everyone to this satellite session. It's great to see so many participants in the room, and welcome to those who are joining us online. My name is Claire Harrison. I'm from London in the UK, and I'm joined today by two very, very eminent colleagues. To my right, Catriona Jameson, who's local, so doesn't have the same jet lag that myself and Francesco Passamonti, who's from Milan in Italy. I also want to extend a thank you to Peerview for setting up this session and inviting all of us, to the Health Tree Foundation, whose introductory video you watched, and to our pharmaceutical sponsors that are listed on this slide, so Bristol Myers Squibb, Geron, GSK and CTI Biopharma, which is a subsidiary of Sobi, who've provided the educational grants for this symposium. If you haven't done already, please could you complete the pre-event survey, and please look out for polling during the presentation. And lastly, please let's make this an interactive session. So this is the QR code for you to scan. I think you've probably had plenty of opportunity to do this, and there are QR codes on the table in front of you. And after this session, you'll also be able to look at the slides, etc. But if you're struggling with this room, which is slightly awkward in terms of, let's say, feng shui or audio, at least visual, I can't see the people in the back right corner, for example, you're welcome to follow along and look at the practice aids now and download them indeed after the event. So let's have a go and ask this first question. Another QR code for you to scan. This will give us an idea of where your priorities are in this field and in this symposium. Is it 1, personalising therapy using JAK inhibitors, 2, use of JAK inhibitors as a pre-stem cell transplant therapy, managing uncontrolled symptoms in patients already on therapy, managing treatment or indeed JAK inhibitor refractory disease, role of newer mechanisms of action and newer therapies in myelofibrosis, or maybe indeed all of the above. So I'm hoping that voting is working for you, and in a moment we'll move on and have a look at the answers. Okay, well, we obviously picked some good topics for the session. So 2/3 of you are struggling with all of the above, but otherwise we're pretty evenly split with personalising therapy using JAK inhibitors, etc. So that's excellent, and thanks all for participating. So in this session, just checking you're in the right place, we are focusing on myelofibrosis. Myelofibrosis is obviously a family member of the myeloproliferative neoplasms, and around 50% of our patients in clinical practice will have had an antecedent disorder such as essential thrombocythemia or polycythemia vera. But today we're going to focus on myelofibrosis. The clinical features of this condition are probably well known to all of you in the audience, but essentially include cytopenias, abnormal blood film appearances, splenomegaly, constitutional symptoms, risk of thrombosis or hemorrhage, and a longer-term risk of leukemic transformation as well as premature death. Turning first to the issue of diagnosis, but also workup of a patient when you're thinking about how will you manage them. And as we are today at the end of 2024, these are the current recommendations from the NCCN concerning a modern comprehensive diagnostic workup for MF. They include, as you can see on the left, sort of standard practice diagnostic workup, and on the right, more sophisticated analysis such as marrow, molecular testing. But we would particularly want to emphasize to colleagues a comprehensive assessment of symptom burden, focusing particularly on things that are of concern to the patient, but also things that are prognostically significant, so constitutional symptoms. Early consideration of stem cell transplant will be something we will be discussing today, and I certainly find in my practice it's good to have that discussion up front with the patient and know if they have an identical or appropriate donor. Now, turning to therapies, as of today in North America, there are 4 approved JAK inhibitors. They're listed on the left-hand side of the slide. Here you can see them. And their targets relating to those which we think are therapeutically relevant, so JAK1, JAK2, ACVR1 for pacritinib and momelotinib, are also summarised on this slide. So despite all of the progress that we've made in treating myelofibrosis, the fact that in just over a decade we've gone from almost 0 to 4 approved therapies, it still appears that there are challenges in clinical practice, and this is what we want to focus on today. This is a study called the METER study, which is a real-world study looking at treatment patterns in myelofibrosis, analysis of almost 1,000 charts presented by Vikas Gupta last year at ASH. And you can see, summarised on this slide, issues. Delay from diagnosis to starting treatment, still quite extensive first-line use of hydroxyurea, and then often patients delaying initiating a second-line therapy. In this study, there were a high number of patients with a significant need, so there were a lot of transfusion-dependent patients and patients with advanced myelofibrosis. As we sat maybe 6 or 7 years ago, we definitely had a need for another JAK inhibitor, and we knew that if we were taking a patient off ruxolitinib as the first approved JAK1 and JAK2 drug, that patients often had a poor outcome. And in this very nice study from Newbury, summarising the MD Anderson experience, what they saw was that for patients who discontinued, survival after discontinuation was poor, and patients could be stratified both by platelet count at baseline, here you see on the left, and platelet count at discontinuation. Clonal evolution also impacted survival. So today, in 2024, we should have perhaps different practice, the ability to move between JAK inhibitors, and what we want to do today is talk about when we might move, what we might choose, and what else might be on the horizon for our patients. So our goals for this symposium are focused on understanding of baseline factors that can inform personalised treatment, augmenting your knowledge of experience, supporting the different JAK inhibitor platforms, but also emerging therapeutics, to give you some guidance based on each of our day-to-day practice, and to equip you with skills that you would need to address treatment initiation, dosing, safety considerations, and also treatment switch. And just to remind you again that we have a very different sponsor also for this symposium, which is the HealthTree Foundation. There are some supporting materials through this website which might be helpful for you in day-to-day practice. So I'm going to start with talking about higher risk myelofibrosis, revisiting the modern role of JAK inhibitors. And I'm going to start with a case. This patient appears several times throughout our session today. So this is Michael. He's a 54-year-old male with a recent diagnosis of primary MF. He's got a 16-centimetre palpable spleen, significant constitutional symptoms. So he's got weight loss, night sweats, but he's got a good functional status. He's got 3% circulating blasts. You can see he's got a leukocytosis and a molecular profile of JAK2, a RAS mutation, and an ASXL1 mutation. His karyotype is normal, and an image of his marrow you can see on the right. So he's got grade 2 fibrosis. So let's have a discussion, Francesco and Kat. In your practice, would you regard this as a high-risk patient, and what kind of prognostic tools are you using? Maybe, Francesco, we could start with you, because you've actually, congratulations, authored many of our prognostic tools.
Claire, thank you for the question. I think that this is a high-risk patient because this patient is a young patient and is a patient with constitutional symptoms that are accounted for an important risk factor in myelofibrosis. The number of blood cells is more than 1 and more than 2, so it's considered a high-risk condition as well. The patient is not anemic, but he presented with leukocytosis and platelet count that is not so low. And if you see the different mutations the patient had, the patient presented with a high burden of JAK2 and the RAS mutation and the ASXL1 mutation. And the presence of ASXL1 mutation qualify for high-risk condition in the MIP70 and the MIP70 plus version 2 as well. So basically, I think that we can consider this patient a patient with a high-risk myelofibrosis. And in my practice, I tend to use IPSS and MIP70 and or MIP70 version 2 plus in the patient at the time of diagnosis. And I try to test NGS to all my patients and also cytogenetics to all my patients. If failing the bone marrow, I test the peripheral blood. And in a patient during the follow-up, I tend to use the IPSS because the IPSS is very easy and we can check the IPSS to all patients during the visit in the ambulatory sections. And for patients with post-PV and post-ET myelofibrosis, I use the MySEC-PM that include the clinical parameter plus the 3 driver mutations.
That's great. So Kat, maybe which features here stand out for you as making this patient a high-risk patient?
I think there's high risk from a mutation profile, ASXL1 being the higher risk mutation here that confers high molecular risk of progression in terms of myelofibrosis and increased risk of acute leukemic transformation. Together with the RAS mutation, we usually look at the variant allele frequency, or VAF, which is fairly high for JAK2 as a driver of fibrosis. But in addition, there's grade 2 fibrosis. So from a MIP70 plus 2.0, this is a high-risk patient. From a treatment standpoint, the good functional status makes them good risk for treatment. So I just see an opportunity here. And, you know, the leukocytosis is something we can tackle. The platelets are still above 100. So there are some good features here. So while this person is high risk by the Mutation Enhanced International Prognostic Scoring System version 2.0, I would say this person has a lot of treatment options.
Okay. So stem cell transplantation, use of a JAK inhibitor. Maybe sticking with you then, Kat?
Yeah, I think most people come in and they want to hear about hematopoietic cell transplantation, but it's not their first choice because of the upfront treatment-related mortality risk. So really most people want to consider a JAK inhibitor as not just a bridge to hematopoietic cell transplant, but maybe a long-term therapy. And whether we add things on to those JAK inhibitors is the main question of the day now. So this is a 54-year-old, so we do have to consider HCT as a real option. But as you mentioned, Claire, we have to do some typing, so usually we refer to our friendly bone marrow transplanters and say, can you get started on the HLA typing, and then we'll start the JAK inhibitor therapy to begin with.
I think as well it's a lot for a patient to take in, isn't it? If you're seeing a patient, telling them a diagnosis, and so jumping straight from, you've got a blood cancer you haven't heard of before, you don't feel well, but you probably don't look that unwell, and then saying, I'm going to transplant you and expecting a lot of processing there is quite tricky, isn't it? And then, Francesco, the platelet count here, would that leave you open to using any JAK inhibitor?
Yes, of course, the platelet count is more than 100, so the patient can receive ruxolitinib or fedratinib as well. And the hemoglobin level is in there, the non-anemic patients. So in general, momelotinib is not indicated if the hemoglobin is over 10. And what is important for me is to use JAK inhibitor according to the platelet count. So we know that we can use fedratinib at the dose of 400 milligrams per day for patients with a platelet count more than 50,000. And concerning ruxolitinib, it's quite important to follow the indication of the dose on the base of the platelet. So it's better to avoid to start with a reduced dose of ruxolitinib, because if we start reducing the dose, we will have less effective on the spleen and symptomatology.
Okay, so I've changed the option a bit now. So we've said we're all, maybe I'll comment on this one, but we're all very comfortable with, we've all gone, phew, the platelet count's over 100, we can use any JAK inhibitor. But now we've got a platelet count of 48. I personally think, well, in London anyway, there would be the option for using mainly ruxolitinib in this setting, potentially momelotinib because the lower platelet count, but the patient's not anemic. Fedratinib we can use, and there is some data which we'll show you shortly for use of fedratinib with platelets between 50 and 100. But we're bordering on something, we chose this level specifically because we're bordering on something where you could perhaps go with a standard dose of JAK inhibitor and support the patient, especially if you're moving straight to transplant. So let's give him a DNMT3A mutation. Ask you question 1, Kat, and then yourself, Francesco, maybe question 2.
Yeah.
Kat, DNMT3A? It's a common mutation that we see, right?
Yeah, so the DNMT3A mutation is something that was discovered by Peggy Goodell as something that drives dysplastic features and clonal hematopoiesis. And in and of itself, we don't really worry about it, but when it comes to hematopoietic cell transplantation, it changes outcomes. So I think we'd really want to look at the treatment option spectrum for this patient. When we see that DNMT3A mutation. I think it also has to be considered in context, though, because ASXL1 is a high molecular risk mutation, and I would be actually more concerned about ASXL1 and that JAK2 V617F VAF more than the DNMT3A.
Yeah, I think I agree. So, Francesca, you've been heavily involved in major developments in this field and have really moved the field forward. If this patient's in your clinic in Milan, would you use a JAK inhibitor alone for this patient?
Yeah, potentially yes, because this is a patient with platelet around 50,000 and the patient is not anemic. And so we can start with JAK inhibition. And I think that in some cases I tend to use danazol because danazol demonstrated to be effective in 15-20% of the cases of patients with thrombocytopenia. The effect is really not so prolonged in time, but I think that we can start ruxo or fedratinib or momelotinib adding danazol with a general idea to keep platelet over 50 and use the correct dose of the JAK inhibitors.
And we had some nice evidence around the use of danazol actually from the Momentum study as well, didn't we? Okay, so these are the summary of our options for this patient. We've all agreed that he's a high-risk patient and we should offer stem cell transplant. And we've discussed in some detail about the management of patients with thrombocytopenia. In the NCCN guidelines, pacritinib has a Category 1 recommendation and momelotinib a Category 2B recommendation. But there's also evidence supporting the use of other JAK inhibitors, as we've reflected. And we've also spoken about DNMT3A. There is some data concerning adverse transplant outcomes for the patients in that setting. So let's take a look at some of the evidence here and reflect primarily on the NCCN guidelines. Here, patients are risk stratified into lower or higher risk myelofibrosis using some of the prognostic scores that we've touched on already. we've already mentioned MIPS 70, DIPS, and the MySEC score, which is specific for patients with a post-ET or post-PV myelofibrosis, as developed by Francesco. Let's see how this patient then has his prognosis calculated using these scores. And you can see here some screenshots. If you use the QR code, you can access the prognostic scores or look at a practice aid. And you can see that on the left, using the MIPS 70, you can see we've filled in all of the answers here. This patient is a high-risk patient with a 5-year overall survival of 34% and a 10-year overall survival of 13%, and very similar with the DIPS plus score. Concerning mutations, we've touched on this a little and pulling out the mutations that we've seen for this patient. ASXL1, RAS mutations particularly have been highlighted in this field as occurring when the patient is losing their response to ruxolitinib. They're not formally recognized as a high molecular risk using the MIPS score. And DNMT3A, which we've called out already. In this meeting, I just want to draw your attention to the fact that there are 2 oral abstracts. These are their numbers on Saturday afternoon, specifically focusing on TP53, which is also not specifically called out in the MIPS system. And then to call out the fact that the CALR type 1 mutation has a better prognosis than the other driver mutations. So it's really important to know what subtype of CALR mutation your patient has. Concerning NCCN guidelines for stem cell transplant and JAK inhibitor therapy, these are well established, and you'll be very familiar with this algorithm. We've discussed it today. Platelets less than 50, pacritinib or momelotinib based on PERSIST-2 or MOMENTUM studies, and over 50, use of either ruxolitinib, fedratinib, or the other 2 agents. And if the patient is a stem cell transplant candidate, they should move on. Just to bring you a little bit more up to date, there have recently been some EBMT and European Leukemia Net allo stem cell transplant guidelines. I won't read out the whole of the slide, but the 2 pertinent changes for me in this paper were, first, that patients should be considered if they have intermediate to or high risk DIPS or a high risk, not an intermediate, but a high risk MIPS 70 or MIPS 70 plus. And then the MTSS score, it's the first time we're mentioning that, that is a score for outcome from transplant. And then there is a specific recommendation about the management of splenomegaly. So Michael should be having a treatment to reduce his spleen size. Stem cell transplantation is a difficult discussion, and it may not always be the answer. And so this, just to call out this data around long-term survival with stem cell transplant, and this is according to the different DIPS scores. And you can see for low and intermediate 1 risk patients that the survival benefit for patients only occurs later, and that's mainly due to early mortality, whereas the survival benefit for intermediate to or high risk patients occurs earlier. And then we also wanted to draw your attention to this paper from Tanya Jain, published this year, concerning the type of donor. So where I practice in South East London, it's a very ethnically diverse population. Very few patients will have a sibling donor, and very few will have an unrelated donor on a panel. So we're increasingly looking to haploidentical donors. So similar outcomes here on the left, but on the right, a significant risk of graft failure for haploidentical transplants. So that's an unmet need going into the next few years. Then a few slides on the use of JAK inhibitors in the peri and post-transplant setting. So ruxolitinib, as we know, has utility in the management of graft versus host disease, but here we are only focusing on outcome after stem cell transplant for MF. So here you can see outcomes and GVHD relapse-free survival sitting at 74%. You can see a cumulative relapse and non-relapse mortality. and then the risks of graft versus host disease, which are particularly a problem for myelofibrosis patients. There is also some real-world evidence published by John Mascarenhas here. Small number of patients, but 18 patients treated with fedratinib before transplant, suggesting that this is also a safe therapy. And the HOVON group have recently presented at EHA the use of pacritinib as an effective pre-stem cell transplant option for patients with myelofibrosis. So if we chose to use pacritinib for the patient we discussed earlier, that would also be reasonable. And you can see here the data regarding graft versus host disease, etc., quite similar. Now, just touching on some of the data with these JAK inhibitors before handing over to Francesco, here is the data for pacritinib with regard to patients with low baseline platelet counts. And this is data from the PERSIST-2 study, which was the study that led to the approval of pacritinib. In this study, we tested 2 doses, but the approved dose of pacritinib, as you will know, is 200 milligrams twice daily. And this is the only data that we're showing here. So we're showing the intent to treat population. Here is spleen volume response 35%, so superiority compared to best available therapy, which did include some low-dose ruxolitinib in this study, and also superiority for symptom responses. And then if you look particularly at those patients with a platelet count of less than 50,000 at baseline, you can see, again, superiority for pacritinib, and also assessing quality of life using patient global impression of change. Many patients had either much or very much improved scores. But as many of you will know, we often use ruxolitinib in the setting of patients with low platelet counts. And so this is a study that was published a couple of years ago, first author is Moshe Talpaz, looking at the safety and efficacy of ruxolitinib in patients with platelets between 50 and 100. And in this study, we initiated the drug at 5 milligrams twice a day and titrated up. And here you can see change in spleen volume baseline to week 24 across the different dosing schedules, and again, TSS. Interestingly, what you can see here is there appears to be a dose-related benefit, at least when you get to 10 milligrams twice daily. There was another study performed in Europe known as the Excel study where we looked at similar data. In this meeting on Sunday morning, there is an oral presentation from Catherine Haifa Al-Ali concerning our second-line study of fedratinib, the FREEDOM-2 study, which was a randomized study looking at patients with high and low platelet counts. And just a quick spoiler, these are the spleen responses and symptom responses for patients according to baseline platelet count. But do go and listen to this oral presentation. So I'm going to ask you a follow-up question now. Thinking back to Michael, here he is, our high-risk PMF patient, splenomegaly, which is palpable, low platelets, but no baseline anemia, is JAK2, ASXL1, and DNMT3A positive. What strategy would you select now, having discussed this literature, for the patient? And there's a Y in brackets after the options. So hopefully you're all online and voting. So would you pursue stem cell transplant without any other therapy? Would you start a JAK inhibitor and consider stem cell transplant at a later date because we know that's the best chance for cure? Would you start a JAK inhibitor but not consider a stem cell transplant because of uncertain benefit? And do you still have some questions to ask us maybe in the Q&A session, where I'm going to encourage you to please also submit your questions. So please do go ahead and vote. And if you voted, you will also have time to submit questions, so do that. And we do want to have an interactive session at the end. Okay, so we've achieved 78% consensus on we would start a JAK inhibitor and then consider stem cell transplant. Certainly in my practice in London, I would be encouraging that patient to go have that discussion early so they've got plenty of time to be thinking about transplant. And now we're going to ask a second follow-up question before I hand over to Francesco. How would you customize JAK inhibitor therapy for first-line use in this patient based on the presence of the platelet count of 48 and a hemoglobin of 11? Would you, 1, use any JAK inhibitor, 2, consider using low-dose ruxolitinib, 3, consider using ruxolitinib or fedratinib at standard dose, 4, consider using pacritinib, or 5, consider using pacritinib or momelotinib? And I might ask you to vote not necessarily according to what's available in your country, but according to the data that you've heard today. Thank you very much. Okay, that's a hint that we're going to see the results. Okay. I think the audience is pretty much split between pacritinib or momelotinib, or indeed low-dose ruxolitinib. I think that's actually pretty reasonable. The platelet count was close to 50,000. Patient definitely needs a JAK inhibitor. Well, that's great. Thank you very much. Let's move on to the next slide, and I'm going to hand over now to my colleague, Francesco Passamonti.
So, thank you, Claire, and it's my great honor to be here with you and Catriona for this meeting. And now we have to go back to our patient, Michael, and just to summarize the clinical picture of Michael. Michael is a 54-year-old man with primary myelofibrosis and a spleen quite large, 16 centimeters from the left costal margin, a significant burden of symptomatology, mostly constitutional symptoms that are the most bad, and a good functional status. The blood cell are 3%, and in this case, Michael have an hemoglobin level of 8 gram deciliter. The patient is anemic, with a severe anemia. Then leukocytosis, platelet count around 100, and the 3 mutation JAK2, RAS, and the SEXL1, a normal karyotype, and as you can see here on the right, a grade 2 fibrosis. The patient, of course, is stem cell transplant eligible for the reasoning we did in the previous presentation, but the donor is not yet available. So I have some questions for you panelists, and what is, Claire, the prognostic impact of baseline anemia in this case?
Well, I think anemia's got a poor prognostic impact in almost any hematological malignancy. In fact, any malignancy, hasn't it? So I was teaching the medical students on prognosis in heme malignancies and said, if you can't think of anything to say, definitely say anemia. So, I mean, yes, definitely anemia has got a strong prognostic impact. I would just want to say that it's super important to investigate this patient for other causes of anemia, because just because he has myelofibrosis doesn't mean to say he couldn't have a concomitant colon cancer, B12 deficiency, etc. And these patients are often also folate deficient. So if he has another cause, then obviously the prognostic impact is different.
Of course, we have to remember that we have general doctors, not only hematologists, focused on myeloproliferative neoplasm. Thank you for this comment. Kate, what will be the burden of red blood cell transfusion for this patient?
So once we've completed the full workup, as Claire had suggested, to rule out iron deficiency, B12 deficiency, colon cancer, other causes of this kind of anemia, red blood cell transfusion dependence is a poor prognostic factor because people get iron overload. And now we can chelate with various iron chelators, but it's still an indication that the marrow is quite fibrotic, as you can see with the grade 2 fibrosis. And you know from the MIP70 plus version 2.0 that grade 2 fibrosis is a poor prognostic factor as well. So it's more of a reflection of that. Nonetheless, there are many supportive strategies as people start to gain a response to their JAK inhibitor therapy or other therapy that we put them on, to think about other ways to reduce red blood cell transfusion dependence. we have clinical trials, particularly for a drug called luspatercept, also known as Reblozyl, which is a TGF-beta antagonist, and that can increase not just the hemoglobin, but we've also seen some responses in the platelet count because it takes off the brakes from TGF-beta, so the megakaryocyte erythroid progenitors can make more of themselves, so you make more red blood cells, but also sometimes more platelets. This is a really important challenge for a lot of patients. We're also trying to reduce the number of transfusions and actually have a slightly lower transfusion thresholds. We're not transfusing if hemoglobins are less than 10, we go to 8.
And I think that we have also to consider the healthcare resource utilization. And we know now there is a nice paper from Aaron Gertz that evaluates the cost of transfusion in terms of transfusion dependency and transfusion requirement, and the cost doubled with respect to patients with myelofibrosis without the need of transfusion. So I think that we have to think of the cost of our clinical situation. And so we have drugs for anemia. One is danazol, another is erythropoietin stimulating agents. So can you comment, Claire, on these two options?
Yeah, so I think they are potentially good options, and certainly in London we would be thinking about either of them, or potentially a different JAK inhibitor. I think useful to measure a baseline EPO level before you start the JAK inhibitor. If you measure it after you've started it, the level will be high, so it's not so predictive. Either of them are reasonable options for this patient, and both of them have been studied in combination, for example, with a JAK inhibitor. But he still needs a JAK inhibitor.
Yeah, I agree. And Kate, how does baseline anemia inform the selection of JAK inhibitor? What is the role in this situation for momelotinib?
I think for most patients, they're really concerned about anemia. It affects their functional status, and momelotinib would be an excellent choice in this case.
So I just want to summarize the sense of this discussion. And we all think that anemia and the risk of transfusion dependency should be recognized as drivers of poor outcome in myelofibrosis, because we have the information of the different anemia level, the transfusion dependency that can have an impact on overall survival and also of transformation to blast phase. And for this patient with uncontrolled constitutional symptoms, JAK inhibitor therapy with momelotinib is recommended as a preferred option for current guidelines. And I just quote the NCCN that we will discuss in my presentation. An alternative option could be also considered including JAK inhibitor, particularly pacritinib, or others such as ruxolitinib, or anemia-targeted therapies such as luspatercept, danazol, or ESAs. So I start with my more formal presentation. So this is an old paper from my group, and here we consider transfusion, this is a retrospective analysis. And we consider here transfusion dependency as the need of at least one transfusion per month that was confirmed in different months. And we can see here very clear on the left that those patients who are transfusion dependent live shorter than those who are transfusion independent. But if you look on the right, this is a rate of patients who became transfusion dependent. And this is already very clear also during the follow-up. And 40% of the patients more or less acquire transfusion dependency during the course of the disease. This is a picture of myelofibrosis before JAK inhibitors. And consider that the hazard ratio in this analysis, transfusion independent versus transfusion dependent, was 7.8. So the difference in terms of survival was really big. And this is a more recent analysis that we did in 1,752 patients with primary and secondary myelofibrosis. And we stratified the patient according to the severity of anemia. So normal hemoglobin and severe anemia, the red one, meaning adjusted for sex, so less than 9 for male, less than 8 for female. Moderate anemia, meaning 8-10 for female and 9-11 for male and not anemic. And you can see here, this is a progression-free survival, so acute leukemia-free survival. You can see here that according to this 3 different threshold of anemia, we have different incidence of acute myeloid leukemia. So anemia and transfusion dependency are drivers of overall survival worsening and higher risk of AML evolution. And I think that the NCCN guideline 2024 were very pragmatic because they designed 3 different scenarios for patients with anemia. One scenario is anemia and the presence of symptomatic splenomegaly and or constitutional symptoms who are controlled by JAK inhibitor. And so the choice is a clinical trial. In general, all these conditions are unmet medical needs, so the clinical trial is compulsory. And the other recommended regimen may include ruxolitinib in combination with luspatercept or with ISA if the serum erythropoietin is below 500, or plus danazol. And as an alternative in special circumstances, we can change to momelotinib or to pacritinib. And the second scenario is a patient with anemia and symptomatic splenomegaly and or constitutional symptoms that are not controlled by the JAK inhibition. So in this case, momelotinib is the preferred option due to the activity against spleen symptom and improvement of anemia. And the other recommended regimen include pacritinib for those patients with a platelet count lower than 50,000, or Rux combination with luspatercept, ISA, or danazol. The last scenario is a patient with anemia without symptomatic splenomegaly and without symptomatology. And I think, as Claire said, that in this situation we have to rule out any coexisting causes of anemia. So bleeding, hemorrhage, hemolytic anemia, iron deficiency, B12 or folate deficiency, and also hemoglobinopathy. And in this condition, we can, of course, favor clinical trials to try to have more responses in the future in terms of anemia, or to use luspatercept or ISA or danazol, or JAK inhibitors such as momelotinib and pacritinib that have a driver with anemia. And lastly, we have also to remember that very few patients with myelofibrosis presented with the deletion Q-, and this patient can respond very well to lenalidomide. So we have to test the deletion Q- not only in patients with MDS, but also in patients with myelofibrosis. Momelotinib has been developed in the phase 3 Momentum study. The phase 3 Momentum study is a randomized study in patients with primary and secondary myelofibrosis with anemia. And patients are required to be symptomatic, to have anemia, and to have a platelet count more than 25,000. And this patient received 2:1 momelotinib at the dose of 200 milligram daily, or danazol at the dose of 600 milligram daily. And all the patients who concluded the week 24 double-blind treatment phase can be offered momelotinib as a open label drug. So here you can have patients who started with momelotinib and then continue to momelotinib, and patients who started with danazol and then cross over to momelotinib. And the primary endpoint was the total symptom score response at week 24, and the secondary endpoint, the transfusion independence rate at week 24, and splenic response at week 24. And so you can see here the responses, and the response rate at week 24 was based on the intention to treat population, so accounted for 130 patients in the momelotinib and 65 in the danazol, while the week 24 analysis, so the response rate at week 24 was based on the number of patients who continue momelotinib, started from momelotinib, or for those who started with danazol and then cross over to momelotinib. And you can see here the results. So at week 24, TSS response was 25% with momelotinib and 9% with danazol. And the transfusion independent rate, that was, I think, the most important impact of the drug was 30% with momelotinib and 20% with danazol. But we have also observed the SVR35 that is quite important in patients that can have anemia and splenomegaly and symptomatology. SVR35 in this second-line setting was 22% with momelotinib and of course 3%, very few, with danazol. And if we look at the week 48, we have 57% of the patients who are transfusion independent with momelotinib and 60% of patients who cross over from danazol to momelotinib or continue momelotinib in this arm. So the rate of transfusion independence was 60%. And also if you look at total symptom score response, it was 45% with momelotinib and 50% with momelotinib at the end of week 48. So there is a confirmation of the efficacy of momelotinib in terms of symptomatological control and transfusion independence, and also in terms of SVR35. But again, we can look also to different anemia threshold, and here we analyze the SIMPLIFY-1 study. The SIMPLIFY-1 study was in JAK inhibitor naive patient. It was a head-to-head comparison ruxolitinib versus momelotinib. And here these are the strata for anemia, so moderate, severe, mild, or non-anemic. And in anemic subgroup, momelotinib was associated with higher rates of transfusion independence and reduced stable transfusion intensity versus ruxolitinib. So this was quite positive. And if you look here on the right and see the trend of hemoglobin increase, you can see that by week 24, there was an increase of hemoglobin in the group of patients with anemia less than 10 gram deciliter, and a stabilization of anemia for those patients with hemoglobin between 10 and 12. Conversely, looking at ruxolitinib, this is a typical picture of ruxolitinib trend for anemia, where you can see a reduction of hemoglobin level. But again, after week 24, those patients who cross over from ruxo to momelotinib have had a quite rapid increase of hemoglobin level in the two populations, so anemic and not anemic. And we also investigate momelotinib with the aim to evaluate the impact of quality of survival in this patient by integrating transfusion dependency with survival data. The blue represents the rate of patients who are transfusion dependent, and the gray those with the time without transfusion reliance. And you can see here that patients treated with momelotinib spend less time reliant on red blood cell transfusion and more time transfusion-free respect to those who receive best available therapy or ruxolitinib. This is a merge of SIMPLIFY-1 and SIMPLIFY-2 study. Basically, anemia benefit with momelotinib suggests in improving the quality of survival in patients with myelofibrosis. But we have also some evidence also in the real-world setting. Of course, the real-world setting is quite important because the patient who have access to the new drugs is quite different from that in the clinical trial. This is an experience from a Spain collaboration. 76 patients treated with momelotinib, some JAK inhibitor naive and other JAK inhibitor exposed. And the hemoglobin level at the baseline was 8.1 and became 9.1 at the end of the follow-up, 120 days. And the rate of patients who are transfusion dependent was 74 at the baseline, and 44% of the patients became transfusion dependent. So these are quite positive results. And in line with this data, I suggest you to see at the poster section the paper from Alexander Rampotas, who found in a UK collaboration a 40% anemia response in a cohort of patients receiving momelotinib in the real-world setting. But now I want to provide some data on pacritinib. Pacritinib has been developed in the PERSIST-1, PERSIST-2 in the PAC study, and the study Pacifica is still ongoing. And this is the information on a cohort of patients who are not transfusion independent and with thrombocytopenia. Non-transfusion independence has been assessed on the basis of the Gale criteria, so at least one transfusion in the last 12 weeks, or according to the simplified criteria, that means one transfusion in the last 12 weeks or hemoglobin level below 8 gram deciliter. And we can see here a significant greater proportion of patients treated with pacritinib achieving transfusion independence. So if you compare this column blue with this one, the difference is clearly significant, 37 versus 7, and 24 versus 4.5 according to the simplified criteria. And this difference is also true if we compare in the BAT group patients who receive erythropoietin stimulating agents. So the best we can do in terms of anemia outside clinical trial of JAK inhibition. And I think that these two sub-analyses are quite important because here we have the analysis in Rux-naive patient, and you can see that the difference is still present. And this can confirm that the activity of the drug is direct and not indirect due to the withdrawal of ruxolitinib. And to observe also this improvement on anemia in the patient with a very low platelet count is quite important in the management of these patients. And we here have analyzed the B-cytopenic patients, so patients with platelet less than 100 and hemoglobin level less than 10. And you can see here the numbers. So SVR 35% was 20%, significantly higher than that of the control. And the TSS reduction was 32 versus 10, significant difference. And if you look here to transfusion independence, it was 26 versus 8.3 with a borderline significance. While we do not find difference in terms of PGIC, so the patient global impression of change very much versus plus match. But of course, the numbers are quite different. But till now, we have discussed about the effect on anemia of JAK inhibitor. Now I want to present a new mechanism of action that is that of luspatercept. Luspatercept is a fusion protein that binds different TGF-beta superfamily ligands with the aim to reduce SMAD signaling and enhance late-stage erythropoiesis. The drug has been developed and approved in beta thalassemia, but also in myelodysplastic syndrome, where we can use in a cohort of patients who are either naive, very low, and intermediate risk myelodysplastic syndrome on the basis of the COMMAND study. But we studied also luspatercept in patients with myelofibrosis, and this is a phase 2 study. We had 4 different arms, 2 arms receiving ruxolitinib and 2 arms in the condition of transfusion dependency. And if you look here, so the primary treatment period, so week 24, we can see that 26% of the patients on ruxolitinib who are transfusion dependent became transfusion independent. 9% of the patients who are transfusion dependent without ruxolitinib became transfusion independent. And if you look at the cohort of patients not transfusion dependent, you can see that around 13% of these patients had an increase of more than 1.5 gram deciliter of hemoglobin from baseline without transfusion. So the drug demonstrated to be effective as a single agent and in combination with ruxolitinib. And if you look at the data of the entire treatment period, you can see that 32% of the patients receiving ruxolitinib who are transfusion dependent became transfusion independent. And then I want to stress your attention on this point because these are the patients that we enrolled in the independent study. And another important point, and I think this is quite relevant for the clinical practice, is the reduction in the number of red blood cell transfusion. And we can see here that either at the primary, either at week 24 or during the entire treatment period, approximately half of the patients who are transfusion dependent had a more than 50% reduction in the transfusion burden. And I think this is quite important. So the luspatercept is now under investigation in the independent study, and I hope that we will have the result of this study approximately before summer 2025. And this study included patients with a diagnosis of primary secondary myelofibrosis, requiring red blood cell transfusions of 412 in the last 12 weeks on JAK inhibitor as a stable dose. And patients were randomized to receive 2-to-1 randomized to receive luspatercept or placebo. And the primary endpoint was the proportion of patients who became transfusion dependent. So we have to wait the result in 2025. So just before concluding, I want to report some information that I suppose are very well known about the dose of JAK inhibitor we have on the market now and some safety consideration that we as a committee decided to stress. The dose of ruxolitinib is on the basis of the platelet. So if the platelet count is more than 200, the dose is 20 milligram BID. If the platelet count is 100 to 150 milligram BID, if the platelet is between 50 and 105 milligram BID. And again, I insist to say that we have to use this dose to obtain the spleen volume reduction that finally can have an impact on overall survival and overall benefit for the patient. What about safety? Anemia, thrombocytopenia, and neutropenia. We can manage these three problems by reducing the dose, stop the dose, or provide some transfusions, or add on some other agent we have now or we will have in the future. We have to assess patients for signs and symptoms of infection. This is quite important, mostly due to the JAK1 inhibition. And I want also to stress your attention on the risk of developing squamous cell carcinoma. And I invite you to read with attention the paper of Alexander Rampotas published on blood, I think early this year. The second drug is fedratinib. Fedratinib should be used at the dose, must be used, at the dose of 400 milligram orally, once daily, with or without food. We have to consider the obvious anemia, thrombocytopenia, and the neutropenia that is typical of the three JAK inhibitors. And we have also to consider that we can have some GI toxicity, but we have to manage it with early implementation of GI toxicity prophylaxis. Doing this, we can see some GI toxicity, especially in the first or second cycle, and then no more. And we have also to test thiamine level before starting fedratinib, and then thereafter periodically. But in general, I see that most of us use thiamine supplementation during the whole course of treatment with fedratinib. Momelotinib is an oral compound, and the dose is 200 milligram once daily. We have to monitor the signs and symptoms of infection, again thrombocytopenia and neutropenia, and reduce the dose, stop the dose on the basis of this value. And you have to consider hepatotoxicity that sometimes can happen. And you also to consider that some patients may have sensory peripheral neuropathy, that in the Momentum study was just below 5% of the cases, but in some academic studies, this is probably much, much higher. So we have to probably select patients without this symptomatology and then check during the follow-up of the treatment. The last drug is pacritinib that must be used at the dose of 200 milligrams twice daily. And of course, this is a drug for patients with a very low platelet count, so below 50,000. So we have to avoid to start this treatment for patients with an active bleeding, of course. And we have also to use antidiarrheal in the cases of diarrhea and reduce the dose or stop the dose if this happens. Thrombocytopenia, of course, is very delicate here. This is a big issue, so we have to monitor very carefully this patient. And also, last comment is to avoid to use the pacritinib for patients with a baseline QTc more than 480, and stop the drug for those patients who develop a QTc more than 50 ms. So the last recommendation we decide to provide to you is, according to our opinion, we have to vaccinate our patient for COVID-19 and to herpes zoster virus before starting JAK inhibition, or also during JAK inhibition if we had not did this earlier. So this is my question for you. So this is to pool. So the question is, this is not a question, but this is just a decision on the patient. So assume that the patient described earlier, Michael, 54-year-old with high-risk myelofibrosis, present with a platelet count more than 100 and uncontrolled symptomatology, but also with anemia. So the patient is a young patient with a platelet count more than 100, symptomatology and anemia, severe anemia. Based on current guidelines, which option would you now consider as upfront treatment for this treatment-naive patient? Option number 1 is ruxolitinib with or without danazol. Option number 2 is fedratinib. Option number 3 is pacritinib. Option number 4 is momelotinib. And option number 5 is any JAK inhibitor. Please vote. You have, of course, to scan to answer, okay? Mm-hmm. I think that this is a very excellent answer to the question of Michael. And mostly of us propose to use momelotinib due to the fact that this patient is symptomatic with anemia. And the other option, ruxo plus danazol. And I'm very happy to have seen this response, and thank you for your attention. And now it's time for Professor Catriona Jamieson. Please,
Thank you very much. Molto bene. Grazie.
Excellent Italian.
There you go. So thanks everyone for coming here so early in the morning. We hope the coffee made it worth your while, and also the ability to have a very interactive discussion we think is very important. You can see there are opportunities for innovation here in myelofibrosis that have also guided how we look at other malignancies. So we're going to change away from Michael, and we're going to talk about a woman who's 74 years old. She has myelofibrosis. She started on a JAK inhibitor. She has CALR type 2, ASXL1, EZH2, significant constitutional symptoms with fever, chills, night sweats at baseline, a little bit of weight loss. She's had first-line ruxolitinib therapy, but lost the response after 2.5 years, despite therapeutic doses. Then she got second-line fedratinib therapy for 400 milligrams. That's the therapeutic dose for a year, but she has grade 3 bone marrow fibrosis, not good. She loses her response to fedratinib after a year and has an increasing spleen size, so that's 12 centimeters below the left costal margin. Now she's 78 years old, and she has a worsening performance status. What do we do? So I'm going to ask Claire the first question. Is this patient currently treatment refractory, Dr. Harrison?
Okay, so actually I can see a few questions coming in specifically on this topic, and thanks everyone for sending your questions in. Do keep them coming. Yes, I would say this patient is treatment refractory. There are no standard criteria for that, but we would tend to use those that have been used in clinical trials, particularly the Freedom 2 study. This patient's had significant duration and good dosing. So for me, this is a patient that's refractory.
And then for Francesco, should another JAK inhibitor be tried, or should we move on to a newer mechanism of action related clinical trial?
I think that this is, as you and Claire said, this is a patient with a refractory disease, and the patient failed ruxolitinib and fedratinib, so 2 JAK inhibitors. And basically, I tend to consider that if you have a spleen in the second line, fedratinib is an option. If you have anemia, momelotinib is an option. So this patient failed 2 different lines of JAK inhibitor, and I think that we have to consider a new clinical trial or drugs with a different mechanism of action, because he already failed 2 different JAK inhibitors.
Great. Okay. Is there a case to be made that this patient should have received some type of combination therapy at baseline, Francesco?
But this is an important point, because we try to do some studies combining JAK inhibitor with other target therapy. And at this ASH meeting, we have the update clinical result of the MANIFEST-2 that compare Ruxo plus placebo versus Ruxo plus pelabresib. We had in the past ASH the TRANSFORM-1 study that compare Ruxo plus placebo versus Ruxo plus navitoclax, and also Ruxo plus selinexor versus Ruxo plus placebo is ongoing. So I think that in the future, we probably have, at least I hope that we will have some combination from the baseline, but for the time being, I think that in the real world it's very rare to combine different mechanisms of action. So we have to work on clinical trial for try to find the best combination for our patients.
So Claire, as a senior author on COMFORT studies with ruxolitinib, FREEDOM studies with fedratinib, what is the role of add-on therapy? Are we at the stage now where we should be considering doublets or triplets in myelofibrosis?
Well, I think we're in a slightly difficult spot. I mean, it's really unusual to have an aggressive hematological malignancy like this, which is managed with a single class of drug. But we've got issues with endpoints, etc. I think there will be a role in the future, but having a path to registration is a struggle. For this patient, there's certainly the option of adding another therapy to try to deal with her spleen. But this would be very personalized.
Okay, so let's talk about treatment options for Amanda. So she has treatment refractory myelofibrosis, and we really need to look at what determines reasons for loss of response. First and foremost, we have to ensure that this patient has been receiving therapeutic dosing with fedratinib or ruxolitinib. The things that I ask patients who are on ruxolitinib is, are you taking a proton pump inhibitor? Because actually the absorption of ruxolitinib goes down if you're taking a proton pump inhibitor. It has to be absorbed in an acidic environment. Secondly, with fedratinib, it's better to take it with food. We saw in the food study in the initial clinical trials that it's better absorbed with food, and it's better absorbed if taken all at once rather than splitting the dose. So some patients are splitting the dose, taking some in the morning, some at night. That's not how it works. They're not going to get the full efficacy. So first we want to ensure that they're actually taking the therapeutic dose. And sometimes people don't want to say, hey, I've missed a lot of these medications because I don't feel good. With ruxolitinib, there's bloating, abdominal bloating. With fedratinib, sometimes people get intermittent diarrhea or nausea. And so we have to look at that and mitigation strategies for those side effects. Be cognizant of challenges with haploidentical hematopoietic cell transplant in older patients. It's not a panacea. I am a recovering bone marrow transplanter. I think I need a 12-step program. I always think of hematopoietic cell transplant as a very good option, but consider that as we get older, our donors get older, and haploidentical conditioning is a significant thing for people to go through, particularly when they have a lot of bone marrow fibrosis. So ideally, we want to reduce the burden of disease before going to transplant. This patient is likely JAK inhibitor refractory and represents a good candidate for enrollment in a clinical trial, testing novel mechanisms of action or combination therapy. And again, when you look at age, so Amanda's 74 years old. We always want to say, oh, good functional status trumps the immune system, but actually as we get older, graft versus host disease becomes much more prevalent in the transplant setting. So that's a very big cause of treatment-related mortality. So let's look at disease modification in myelofibrosis in the era of targeted therapy. So if you look at normal blood development, that's really dictated on having a healthy bone marrow microenvironment. And by definition, in myelofibrosis, the bone marrow microenvironment is not healthy. It's scarred. And sometimes it's scarred so much it goes beyond reticulin or collagen fibrosis to actually osteosclerosis, which is bone deposition in the intramedullary cavity. The other things we see are clonal expansion of hematopoietic stem and progenitor cells, these mutated clones. And we also see a lot of inflammation in the bone marrow. That inflammatory cytokine signaling begets disease progression and clonal evolution, as Claire alluded to. And then we see neoangiogenesis in the bone marrow. So in terms of the bone marrow and beyond the bone marrow, usually what happens is people really start to notice constitutional symptoms, fever, chills, night sweats, weight loss, pruritus. They're itchy all over. They have muscle aches, joint pains. And what I find in most of my patients, and I saw 16 on Wednesday here in my clinic in San Diego, is that almost everybody has to get horizontal by 8 p.m. They have to put their feet up. So the main symptom is profound fatigue. And that's really what we're fighting here. It's not just anemia. There's fatigue associated with inflammatory cytokine signaling. And of course, we get concerned about cytopenias and the risk of secondary acute myeloid leukemia, which if somebody transforms to secondary AML, that confirms a life expectancy of 12 months. So we've got to make sure to predict, prevent, and we have strategies to try and reverse that. But actually the biggest problem with advanced myelofibrosis is actually bone marrow failure. And the cytopenias related to bone marrow failure that put people at risk for infections. And those are the main complications of myelofibrosis. The number one reason for death is actually infection, pneumonia in particular. We also see thromboembolic events, hemorrhagic events, and ultimately organ failure. But the good news is we see this far less often now. We used to see people who would come in, they'd have massive splenomegaly, their extramedullary hematopoiesis would have switched over to their liver, they'd have liver failure with ascites. Now, because of meetings like this, thank you PeerView, and thank you all for being here and being patient advocates, we don't see that very much. So if you or a family member has myelofibrosis, please come to one of our main sites to be seen. You actually really deserve to be seen at a major center for this. And most of us are available online for questions as well. So basically, we're all pushing toward early intervention. I'm part of the NCCN panel, National Comprehensive Cancer Network panel for myeloproliferative neoplasms. This was the brainchild of Ruben Mesa. He said, we have to start this. So we did that back in 2016. And so the whole push now is early intervention, not watchful waiting. I don't know what we're waiting for. We're waiting for disease to progress. So that's my strong plea there, get diagnosed early. There's greater potential for disease modification and improved prognosis. Later intervention, there's less scope for reversal of bone marrow fibrosis. And when we first started in the, targeted therapy setting, we thought you couldn't reverse bone marrow fibrosis. And now what we're finding is we can, again, provided we intervene early and we can normalize hematopoiesis or blood development. So there are newer mechanisms that we're considering now in the context of clinical trials. We've got the capacity to target some cell surface drivers of disease progression. CD123 is one of them. This is the IL-3 receptor. We can do that with an interleukin-3 that is actually conjugated to diphtheria toxin, and that prevents signaling through the IL-3 receptor. So that IL-3 receptor is upregulated on leukemia stem cells during disease progression. This is a very, very potent strategy, but is also associated with some capillary leak and hepatotoxicity, but is looking very interesting. The Cartos inhibitor that has moved through clinical trials very nicely is very promising. It's an MDM2 inhibitor. MDM2 actually inhibits our tumor suppressor, which is called P53. So if you get rid of MDM2, you're more likely to have that wild-type tumor suppressor work. So this drug is for people with wild-type, not mutated P53, but that is fairly common in myelofibrosis. If you look at the JAK inhibitors, what are we combining with the JAK inhibitors? BET signaling. So why does this BET signaling matter? We're betting on inhibiting both JAK and BET signaling because BET signaling leads to pro-inflammatory cytokine signaling. And we don't want those inflammatory cytokines to drive JAK2 STAT3 signaling because that leads to disease progression. So we've got pelabresib, we've got a couple of drugs here, bromidemstat. Never forget 5-azacitidine, decitabine. Vidasa, as you know, is now oral, Onureg. That has some activity as a hypomethylating agent in people who have some increased circulating blasts. And you saw Francesco had a patient with 3% blasts. Michael, in his situation, that person could progress to have more blasts. So it's something to consider. I think one of the really exciting things to consider for patients now, again, in the context of clinical trials, is telomerase inhibition. So telomerase inhibition with imetelstat is actually a completely different mechanism of action, and that's something that is still transitioning through clinical trials but looking very promising. What about JAK inhibition? JAK2 V617F, that's a point mutation at nucleotide 1849 that leads to the valine to phenylalanine mutation in the pseudokinase domain, so you basically can't shut off JAK-STAT signaling. Could we have a mutation-specific JAK inhibitor? Remember that JAK2 V617F signals through STAT3. So if that JAK inhibitor is specific for the mutation, it has to block phospho-STAT3 signaling. Just something to think about. Calreticulin. How do we target that? This is about 25% of patients with myelofibrosis. I tend to see pretty young patients with essential thrombocythemia. This is more of these patients, 25-year-olds. I think we were just missing it before because we weren't doing molecular testing for people with migraines and constitutional symptoms. Anyway, this is looking really exciting. So we can target calreticulin. It's on the cell surface. It was thought to be an ER chaperone gene, but now we understand from work done by Anne Mullally that it actually partners with the thrombopoietin receptor. So by targeting calreticulin, we can make that internalize and no longer signal. So there are a couple of strategies there, peptide vaccines, but also an antibody strategy to target calreticulin. So you'll hear more about that at ASH. And then we've got BCL2 and BCL-XL inhibitors with navitoclax being very potent. So I wanted to focus a little bit on telomerase. As you know, Elizabeth Blackburn won the Nobel Prize for discovering telomerase. This target in myelofibrosis is very important because it's overexpressed by the malignant hematopoietic stem or progenitor cells. So that creates a great Achilles heel to go after. So if we come in with imetelstat, it can induce apoptosis in these malignant cells and allow the normal stem cells to take over. So how does it work? So telomerase has an RNA component that primes the mending of the telomere ends, which are at the end of all our chromosomes. So basically, as a telomerase inhibitor, this is a 13-mer oligonucleotide with this lipid tail that increases cell permeability, and it has real disease-modifying potential because it kills the malignant stem or progenitor cells, and again enables normal blood cell production. So when you look at imetelstat in the relapse refractory setting like this patient with myelofibrosis from the IMbark trial as published by John Mascarenhas, what we saw with patients who were randomized to either 9.4 mg per kg or 4.7 mg per kilogram IV once every 3 weeks is that we had quite a nice reduction in spleen volume and symptoms really at that 9.4 milligram per kilogram dose. Treatment with imetelstat 9.4 milligrams per kilogram led to a median overall survival of almost 30 months. And again, bone marrow fibrosis improvement. Remember, in the beginning of all these targeted therapy trials, we were very nihilistic. We thought you could never improve bone marrow fibrosis, but now we know we can with drugs like imetelstat. In terms of treatment emergent adverse events that are grade 3 or higher, anemia is fairly common. We heard from Francesco about how to treat that. Thrombocytopenia, 41%, and neutropenia. But nonetheless, that overall survival kind of gets our attention, almost 30 months. That's very good. So what about biomarkers? How do you, the main thing for all of us who are in clinic, whether you're a physician or a patient, is we want to be able to predict who's likely to respond to imetelstat. So again, John Mascarenhas and colleagues in the IMbark study looked at this and really looked at overall survival with change or stabilization of bone marrow fibrosis. So if somebody's in clinic, then they've never had a bone marrow biopsy, That's a problem. How do you judge bone marrow fibrosis without a bone marrow biopsy? So this is dependent on getting a bone marrow biopsy. And so basically what we see is a reduction in the grade of bone marrow fibrosis actually correlates with overall survival. And so that was very intriguing. The other thing that seemed to correlate with an improvement in overall survival, again, I think something we didn't think we could change, but if you target the leukemia stem cell, you can, is the reduction in the variant allele fraction or frequency. So greater than a 20% reduction in VAF is associated with improved overall survival. So how do you further assess this? You know, we all got excited about the Geron trial in the phase 2 setting. How do you know it's better than standard of care? So this is all about randomizing patients who have refractory disease to imetelstat versus best available therapy. And that looks at patients who get the 9.4 milligram per kilogram dose every, 21 days, and then we have the end of study visit. So post-treatment follow-up has been key here. The plan is now to add on therapy, because the problem with the trial that I just talked about is you have to take people off their JAK inhibitor, saying they're completely refractory to JAK inhibitor. But actually, usually the case is people are suboptimally responsive. And so this trial, MYF1001, addresses that and adds imetelstat to ruxolitinib. And then we'll see how people do with that combination and to see if they have better responses over the long term. So what about add-on therapies? I mentioned MDM2, navtemadlin in myelofibrosis. This is a very interesting mechanism of action. This blocks MDM2, and that will allow our tumor suppressor P53 to actually work. So this works in wild-type myelofibrosis, wild-type P53 patients who experience, again, a suboptimal response to ruxolitinib. And you can see that spleen volume response at week 24 actually looks quite good. So we're interested in the outcomes there. So this is really for patients, again, with wild-type P53, with primary or secondary myelofibrosis who are resistant or refractory to JAK inhibitor therapy. 2-to-1 randomization, navtemadlin, this used to be called Kartos, and you can see it's 7 days on, 21 days off, 28-day cycle trial, 240 milligrams compared to best available therapy. So this one is going to be very interesting to watch. Poesis will test add-on therapy with this MDM2 inhibitor in the suboptimal response. And I think that's really what we're all excited about, adding something when we see a suboptimal response. So you see in this case, for people that have had a spleen volume response that is less than 35%. These are the patients to consider, or people that have a total symptom score that really hasn't been reduced to less than 50%. So this is where we add on this MDM2 inhibitor and then look for responses in terms of spleen volume, total symptom score, red blood cell transfusion, independence, and ultimately overall survival. So the question is, can newer mechanisms make a difference in the first-line setting? These trials have been challenging but very, very interesting. So when you look at the phase 3 MANIFEST-2 trial, when we did this study, it was really to see, should we be taking patients early on that have some higher risk features and adding on this BET inhibitor to ruxolitinib, the BET inhibitor called pelabresib. So when people have a spleen volume response of 35% at week 24, when we look at that, it was significantly greater in patients with a combination versus placebo combined with ruxolitinib. So that was pretty impressive, actually, with this combination. And again, we think it's working by inhibiting inflammatory cytokine production. If you look at reticulum fibrosis, that also went down in just over a third of patients. And, you know, that's pretty substantial for people to consider that, because that means it's really a disease-modifying combination. So we're interested in the results in, fibrosis and also VAF that we're starting to see. You'll get an update on this at poster abstract 3178 on Sunday at 6 p.m. So please check out that poster. I think that's going to be very important. I should mention for BET inhibitors, we did see a slight increase in leukemic transformations, so that's something to really watch for. Don't ignore it. This is something that Francesco mentioned. Something that looks very interesting is selinexor. So what this does is it traps BCL-XL in the nucleus, and it prevents export so it can't promote survival of the malignant stem cell populations. When combined with ruxolitinib, this is showing some significant activity in patients with myelofibrosis. It's a phase 2. 84% of patients had a reduction in spleen volume, and about 40% achieved a spleen response. So that one, keep your eyes on that one. That's an oral abstract, 1002 in your abstract book on Monday at 5:45 p.m. And then it's back to the activin receptor, type 2A ligand trap. That was tested as a monotherapy in combination with ruxolitinib, so elritercept, improvement in hemoglobin and transfusion burden with maintenance or increases in platelets. So kind of similar to luspatercept, but maybe slightly more potent. There's also potential for spleen and symptom improvement. And then we're moving on to newer classes of BET inhibitors. These have been tested in combination with Rux in relapsed refractory myelofibrosis and other myeloid neoplasms as well, with some suggestion that there are improvements in spleen volume and also some symptom improvement in 13 and 19 patients. Oral abstract 658, Sunday 5:15. And then finally, a serine 3 kinase inhibitor, PIM1 kinase. We tend to see activation of PIM kinase as people progress in myelofibrosis, like this patient, Amanda. There's a phase 1-2 study in patients with primary myelofibrosis or secondary myelofibrosis previously treated with or ineligible for JAK inhibitor. Spleen volume response 25, symptom improvement, bone marrow fibrosis reduction, hemoglobin platelet responses have been seen. Please look at the abstract 655 on Sunday, oral abstract 4:30 p.m. So thoughts from the panel. I think we're going to think about, obviously, answering your questions, but what has not changed? What still needs to be developed? My lab works on ADAR inhibition. I still think we need to do that. For Rick in the audience here from the MPN Research Foundation, maybe there's an opportunity for base editing out some of these point mutations with base editors. We need to do a comprehensive assessment of patients at baseline, carefully planned and absolutely personalized treatment selection with precision prognostication. That's the current standard of care. And consider all the available options when making treatment decisions. Hematopoietic cell transplant and JAK inhibitors are pillars of our modern management. But in the future, we'll be considering combination add-on strategies with different mechanisms of actions. And when you can, consider a clinical trial where possible. This is a follow-up question on your device. Reconsider a patient with myelofibrosis who has progressed after treatment with first-line Rux and second-line fedratinib at therapeutic doses, who now presents with increasing splenomegaly, grade 3 fibrosis, and return of symptoms at 78 years of age. Assuming all are available, what strategy would you turn to next? Are you unsure of what to do for this patient? Should you re-challenge with ruxolitinib? Should you increase the fedratinib dose, consider a different JAK inhibitor, or move to a clinical trial with a newer mechanism of action, either as monotherapy or combination with a JAK inhibitor?
Okay, so while you're voting, oh, you already voted. Handing back to Kat.
There you go.
So fast.
People are very decisive. Yes, clinical trials are always the right answer. Thank you. And available.
Okay, excellent. Thank you so much, Kat. So now we're going to move to the Q&A session. But while we do, I do have to announce some winners of the Amazon prize. And Amanda is over there. So if you would like to, so Renato Tavares, Maggie Maguire, and I've lost the name of the last person. I can see his question, which was an excellent one.
Renato Tavares.
No, Renato Tavares, Maggie Maguire, and I think it was Tristan Bice. So Maggie, Renato, and Tristan. Congratulations. And so we can take questions from the floor. Apologies, I can't see the back right of the room. So if you have a question and you want to ask it, there are people roving around with microphones. But in the meantime, we do have some excellent questions that have actually come in. And I'm going to ask my colleagues to pick one or two each. So, Kat, I've already picked mine. I'll hand you this iPad.
Thank you.
So one question was, what about the role of interferon in myelofibrosis? And I'm going to couple that with a question that came in asking about the combination of interferon and ruxolitinib. I think I would say that there are some small number of publications about the role of interferon as a monotherapy, principally from the French group. Jean-Christophe Ionoto has published a couple of nice papers, and there's an ongoing study with Besremi. My feeling is it's better to intervene earlier with interferon, say in lower risk patients. That's the treatment I would choose. And there is some data, again, very nice data from France on the combination of ruxolitinib and interferon. Doesn't seem to be taken forward, but for me, that seems a really exciting and interesting combination. And then just before handing either to anyone in the room who wants to ask a question, so do put your hand up and wave if you do want to. There was a question about refractory splenomegaly before transplant, but let's move to you, sir.
I can stand up, Claire, thanks. It's Rick Winokur from the MPN Research Foundation. So, you know, your work in the MAGIC-PV study really showed beautifully the impact of ruxolitinib on the variant allele frequency of JAK2. What do we know now about what's happening with JAK inhibitors with myelofibrosis in terms of long-term treatment and their ability to suppress the variant allele frequency and its connection with long-term outcomes?
Thank you very much, Michael. That's a great question. I can see there's another question also at the back of the room, so we'll take that one too. I would say that there is some data suggesting that JAK inhibitors can reduce, for example, the JAK allele burden. There's a very nice oral presentation as well at this meeting about the calreticulin mutation that's being presented by Zhi-Ng in a collaboration between our group and France. But we don't know enough about depth of that response, and it's very complicated in myelofibrosis because of the presence of other mutations. Nonetheless, I do think a molecular response is probably an important target that we should be going after, and will be increasingly of interest with mutation-targeted therapies. Thanks for the question. Shall we maybe go to the question at the back of the room? Thank you so much.
Thank you for all the information. My doubt is about the other JAK inhibitors, because many of the new mechanisms of action that you have already mentioned are being evaluated with ruxolitinib. But what happens with patients that have a low platelet count that may need not ruxolitinib but pacritinib or other JAK inhibitors to have this security that it will be a better option for the patient, this combination? Thank you.
I think this is a very nice question, because this patient are patients with a low platelet count, and which is the alternative in the case of failure of JAK inhibition or a combination trial. So of course, you know that if you use a JAK inhibitor as a backbone in the combination, you probably have a high effect on the reduction of the platelet count. So in those patients, you need a partner to JAK inhibitor that have no effect on the platelet, or a very limited effect on the platelet. So for instance, in some cases, I don't know, ruxo plus interferon, but we are discussing about the very early phase of myelofibrosis. But in the real phase of myelofibrosis, so the overt phase of myelofibrosis, it is not easy to design a combo study in this setting. And in the next days, you can see a result of a PIM inhibitor, nuvisertib, that show efficacy in terms of platelet increase in this cohort of patients. You can also see as an oral presentation the result of the Freedom 2 fedratinib that seems to be able, this is a randomized study, so of course it is able to increase the platelet early after switch from the first line to the second line treatment. So I think that the question is quite important, and outside the clinical trial, I tend to manage this patient adding on danazol, for instance, that is active in patients with a low platelet count. And I suggest to be very careful in case of prostate problems, and to check prostate and to check also transaminases. And this is my practice. But this is a very important point, because these are patients who can need stem cell transplantation, because having a very low platelet count is one of the risk conditions. So that's an important point and a real unmet medical need. Thank you for the question.
Thanks.
I agree, complete unmet medical need. Kat, did you pick a question?
Yes.
There are so many great
you know,
questions.
we're here in San Diego, so I have to say something in Spanish, because 30% of us speak Spanish in San Diego, just saying. So from Santiago Rosforteza, paciente con anemia basal, hemoglobin 8, preinicio con momelotinib con esplenomegalia, tras 6 meses sin mejorar. ¿Qué hacer cambiar a otro inhibitor JAK2 cuál? So this is very similar to the last question. So this person, Santiago, is asking, you have a patient who has a baseline hemoglobin of 8, and they get started on momelotinib. They still have splenomegaly at 6 months without any improvement. What should you switch to in terms of a JAK inhibitor? So it's a very similar question to the last one. That's why I wanted to follow up. Because you do have other options. You have fedratinib as an option. Again, rule out other causes of anemia, as Claire brought up in the very beginning. Think about people with advanced myelofibrosis tend to have varices, and they may have intermittent occult GI bleeding. So we always check for that. And then think about pacritinib. And of course, momelotinib, as we mentioned, has to be dosed at the right level. And the right level dosing may be precluded by neuropathy. So there's a question about neurotoxicity from momelotinib, which is more of a peripheral sensory neuropathy. If you get it, don't continue momelotinib. It's really hard to deal with that later on.
Great. Are there any other questions in the room? If not, I will ask Francesco to pick a question. And while he's just looking, there are a couple of nice questions on pre-fibrotic myelofibrosis. Great questions. Thank you so much to those of you who asked those questions. This disease is not the same as myelofibrosis, and there's very little data regarding how to treat it. But if the patient has a phenotype of myelofibrosis, but just misses on fibrosis grade, I would say my personal practice is to treat them as myelofibrosis. But sometimes they will look more like a patient with PV or ET. We could do a whole session on pre-fibrotic myelofibrosis, but not quite the same. Thanks for the great question. Francesco or Kat, did you want to
Yeah, I
comment?
just wanted to mention there, Pegasus has a role there as well.
Yeah.
So that's something to consider for your patients. That's pegylated interferon, and of course we have Ropeg now as well. Usually I start with Pegasus because there is some activity, according to Ron Hoffman and Dick Silver and others, in that pre-fibrotic stage. And sometimes you can reduce that little bit of fibrosis there. So that's a good way to go.
I found a very nice question about endpoint of clinical trial. And for instance, I just comment this within the context of prefibrotic MF. I think that this is a condition that is much more indolent than overt myelofibrosis. So when we think to design a study in this condition, probably we can use as endpoint the progression-free survival or splenomegaly-free survival or overt myelofibrosis-free survival. So something that can prevent the progression of the disease. And the prevention of the progression of the disease is quite important in these disorders. And there is another question about AML occurrence in the era of a JAK inhibitor treatment. And we have to say that the global impression is that the number of leukemias in patients who receive JAK inhibitor is just slightly reduced, but formally we have still cases of AML under treatment with JAK inhibitors. And then there is another question that is on luspatercept and why, which is the hypothesis about the high efficacy of luspatercept in those patients who received luspatercept plus ruxolitinib. And one of the hypotheses is that, of course, there is a synergistic effect among the two drugs, and the JAK inhibitors function as anti-inflammatory drugs, so reducing the inflammation that can induce anemia, and also of course the push on the late stage erythropoiesis. Probably this is the explanation.
Well, great. Just a couple of comments then on, there was a question about refractory splenomegaly before transplant, and the role of maybe splenic irradiation or spleen removal. I think it's still important to get to transplant if you're intending to do that and your patient agrees. And the data suggests that the time to best go to transplant in a patient with an optimal donor is before the patient loses their response to the JAK inhibitor. But I would say if the refractory splenomegaly is 6 centimeters versus the 5 in the guidelines, I wouldn't be so worried. But clearly, if it's a very big spleen, there is some data on splenic irradiation or the addition of other agents, for example. But if you do splenic irradiation, be ready for pancytopenia and be ready to need to move to transplant for the patient.
Yeah, I wanted to comment on that as well. What we've had before with splenic irradiation is the extramedullary hematopoiesis just moves to the liver. And now you've got somebody who has liver dysfunction, and you're trying to get them to transplant. It's kind of a tricky thing. A lot of people say, just take my spleen out. Well, there's more mortality related to splenectomy in people that have massive spleens. So just the better thing, or I think the more likely thing to work is really push the doses of your therapy to try and reduce the burden of disease as much as possible before getting to transplant.
And in this way, the radiotherapy on the spleen must be done just before the conditioning, so close to conditioning, just to avoid other problems. And I don't know if I can, but I want to do some auto-promotion, because Saturday afternoon, Nico Gagelmar will present a huge study on the clear indication of the timing of stem cell transplantation in myelofibrosis. So this is a good approach, and we aim to define the exact timing according to the different risk category to proceed to stem cell transplantation.
Important. Thank you so much. That's a great shout out. I'm certainly looking forward to hearing that presentation, because this is for sure one of our tricky scenarios in the disease. So are there any more questions in the room?
I actually wanted to talk about precision prognostication. We talk about looking at JAK2 V617F or CALR variant allele frequency together with high molecular risk. How do we monitor that going forward? How important is that, and how often should we be doing that? So a lot of our centers have access to next generation sequencing. We tend to do it twice a year in people with higher risk features who are considering hematopoietic cell transplant. And so, is it all about DNA mutations, or can we consider RNA alterations? So as we start to move towards single cell RNA sequencing, we think there will be some molecular predictors of response and therapeutic resistance based on RNA, so that's something to watch out for. And with the electronic medical record having the capacity for research, we may be able to mine databases, for example, the COMPASS database in EPIC, where I think, is it 280 million people on EPIC now, Claire?
Certainly some more in Southeast London as well.
Yes. So that's a COMPASS database. So we'll be able to see in the 280 million people, and this is just one example of EPIC, their database, how many people have myelofibrosis, what are their treatments, and if we post the genomic studies there, we'll be able to see in aggregate, how do people do in a real world setting? So that's something to watch out for in a good way, I think. We'll know more going forward.
Okay, so I think we'll probably close here. I'm so impressed, again, to see such a full room. It clearly speaks to the fact that my colleagues gave fantastic and give fantastic presentations. Thank you so much for all of the interaction online, and thank you to our online listeners and sponsors. I wish you all a really good ASH. Do go and see the presentations that we've highlighted today, and do complete and submit your post-test and evaluation, because this helps us to generate content that is relevant for you. Thank you so much and have a great ASH.